Okay, good afternoon, everyone. We're going to be talking about common neurological presentations, specifically focusing on CVA strokes and head injuries. So we're going to start off with stroke. So firstly, what is a CVA or stroke? So it's defined as an acute neurological impairment that follows interruption in blood supply to a specific area of the brain. There are two major types of strokes. The first is an ischemic stroke, which is the vast majority. In America, it's about 87% of strokes, and it's usually due to an occlusion of an artery to the brain, which can be from an embolus or thrombus. The second type is hemorrhagic stroke, and that's when a blood vessel in the brain ruptures into surrounding tissue, and that can be subdivided into intracerebral, subarachnoid. So with the two types of strokes, as you can see in the picture, an ischemic stroke will have the blockage of the vessel, which I said could be a thrombus or an embolus, and distal to that blockage, there will be no blood supply, and that area of the brain would then not be perfusing. On the other side, a hemorrhagic stroke would be when there's a rupture of the vessel, and so the vessel breaks and it bleeds or hemorrhages out into the surrounding tissue. And then so those are the two main types of strokes. So well, we want to just discuss first, why is it an emergency? So we've always heard with that time is brain, and they also say time is tissue with a myocardial infarction, and it's a similar thing because the brain tissue is not perfusing, it's not receiving oxygen and nutrients. The second reason why it's such an emergency is that the therapy is time sensitive. So as we'll discuss shortly, there's a window of opportunity where we can limit the damage and really change a patient's outcome if we can get them within 4.5 hours for reperfusion therapy or 24 hours for endovascular therapy. And lastly, because the earlier the treatment, the better the prognosis, because every minute, literally, tissue is being lost. So the earlier, the better. So in order to treat the stroke, we first got to recognize the stroke. So the paramedics, and they use the mnemonic B fast for recognizing signs of a stroke. So the B is the balance. Does the person have a sudden loss of balance? Have they lost vision in one or both eyes? Do they have asymmetry of the face, or does their face look uneven? The A for arms, but it can really be arms or legs. Is there weakness, usually asymmetrical weakness, one side more than the other? Is the patient's speech slurred? Does the patient have trouble speaking? Are they confused? And if they have any of these criteria, then it's time to call 911 or here EMS. So while these signs can be suggestive of a stroke, there are other things which can mimic a stroke, and it's important for us to just have them in the back of our mind. And an important one, for example, is a TIA, or transient ischemic attack, sometimes referred to as a mini stroke. And this is where it can present exactly like a stroke, except that the symptoms resolve within 24 hours. However, it's really important that we don't just say, okay, the patient doesn't have any deficit anymore, we can send him home, because this can be a warning stroke that in the next few weeks, the patient may have a stroke. And it's important to address this issue to prevent the stroke. So the patient who has a TIA should be put on secondary prevention, which we'll discuss at the end of this section. Other causes to consider are like if the patient's epileptic, post-ictal phenomena. A common one which occurs is hypoglycemia, because this hypoglycemia can actually present with focal neurological deficit, and it's so easy to treat. So it's really important to always do the sugar levels. Another one is intoxication or infections, and also conversion disorders. So this is just a little mnemonic we found on the internet, just to keep in mind whenever you're seeing someone with a stroke, to rule out these mimics, because these things can be treated. So as we said, in managing a stroke, we first need to identify that the patient's having a stroke, and you activate the emergency response. Now, with any patient, we always start off with our ACLS principles, our airway, breathing, circulation. So is the airway patent and protected? And it's always important to keep an acute stroke nil per os in the meantime until you've done a swallowing assessment, so they don't aspirate, can affect their breathing. Circulation, you need to avoid hypotension. You want to keep the maps at least above 65, so that the brain is perfusing. You want to document their neurological function, and you want to also just expose the patient, look for any signs of trauma, medical alert bracelets, or anything else which can give us a sign of a stroke mimic. Then they say DEFG, don't ever forget glucose. As we said, hypoglycemia can mimic a stroke exactly with focal deficits and everything. So always important to check their HGTs. And then you take a history from the patient. We can use the mnemonic sample. So you look for signs and symptoms. Does the patient have any allergies? Are they taking any medications? Past medical history. Have they had a TIA in the past? Do they have risk factors? Hypertension, diabetes, cholesterol, their last meal, and then if they've been drinking any alcohol for like intoxication. And then you want to know what happened. And under what happened, it's really important to figure out when was their last known normal. So because we take that, the time that the patient was last known normal is time 0. And from that is when the clock starts ticking for our window of opportunity for intervention. So in the primary healthcare setting, the most important priority in acute management of a stroke, once we've stabilized the patient, is to ensure that the patient gets a non-contrast CT scan. The reason it needs to be non-contrast is because in the acute setting, blood or hemorrhage is also white. So if you give them contrast, you can actually miss a hemorrhagic stroke. So we do a non-contrast CT brain to rule out a hemorrhagic stroke. If it's a hemorrhagic stroke, then they go down a different pathways. You speak to neuro ICU, see if they for neurosurgical intervention. However, if it's an ischemic stroke, then we start considering if they're a candidate for fibrinolytic therapy. So our first priority is in the primary healthcare setting is to identify that the patient is having a stroke and get them to a center which can do a non-contrast CT brain. Ideally, paramedics shouldn't be bringing a stroke patient to a clinic. They should be taking them to an acute stroke-ready hospital or stroke center where the patient can get a CT brain within 20 minutes and have fibrinolysis. But it does happen that they do bring to the clinics, and that we do have walk-ins. And so I know normally we can wait 2-3 hours for EMS to get a patient, but it's really important that we push patients who, if they are in the window of opportunity, to get to a center as soon as possible. And the literature does show that there is an advantage in better outcomes for patients who go to a stroke center than to just any hospital with a CT scanner. So in the public setting, there are quite a few centers which offer fibrinolytic therapy, and that's within 3 to 4.5 hours of symptom of onset. There is also the option of endovascular therapy. I think in South Africa, the only center which does this though is Mill Park, but I'm sure it will be something which will come to our settings. So it's important to know about it as well. So our aim with fibrinolysis is to open the blocked vessel and limit the size of the stroke to prevent further damage. So when someone has an ischemic stroke, there's something known as the ischemic penumbra, which is the area of the brain tissue, which in the middle is the infarcted or dead tissue, and around it is the at-risk tissue. So we want to prevent the at-risk tissue from becoming dead tissue. So we need to reperfuse this area as soon as possible, and therefore limit the deficit that this patient will be left with. It's really important then to also find and treat, if possible, if you find the cause of the stroke, because you don't want the patient to have a stroke again. If they're in AFib or whatever the cause is, you need to investigate it. So now with fibrinolytic therapy, there are there's called the fibrinolytic checklist, which a patient would need to go through to see if they are a candidate for fibrinolysis. So it's not relevant for us in the primary healthcare setting, because we're not going to fibrinolyze a patient in our setting until they've had the CT scan, because one of the major absolute contraindications is a hemorrhagic stroke. So until they've had their non-contrast CT scan, it's impossible to know if they will be a candidate, but this is just an important reference for ourselves to know if they are going to be a candidate. So now coming to what we can do again at the clinic level is secondary prevention. So once a patient has had a stroke, if they had fibrinolysis or they haven't had it, we need to now help optimize the patient. So this needs to be done with a multidisciplinary team. And as I said, with the stroke center, a dedicated stroke environment has shown to give better outcomes with doctors, nurses, physio, OT, speech therapists, social workers, psychologists, dietitians. And you need to address the modifiable risk factors and optimize comorbidities such as hypertension, diabetes, cholesterol. Now, even if a patient doesn't have hypertension or cholesterol, we do still start them on a statin, an antihypertensive. And if the patient was not thrombolized, we start them on aspirin as long as they don't have a hemorrhagic stroke. If they were thrombolized, then you don't start aspirin for at least 24 hours after thrombolysis. And these will be lifelong measures now to prevent them from having a second stroke. If the patient's immobile, it's really important to consider DVT prophylaxis, turning the patient, preventing pressure sores, regular physical exercise. And it's also important for these patients now. It's had a devastating effect on their life, and you've got to see, how's it going to affect them in the workplace? Do they need a disability grant? And then, as I've mentioned on the slide here, SSRIs are really important as well, because a lot of patients with post-stroke do land up with some element of depression, and specifically SSRIs have been shown to have a favorable outcome in patients who do develop depression post a CVA or stroke.
Okay, so I'll be talking about head injuries. Next slide. Okay, so why is it important? So in our South African setting, where there's a lot of trauma, head injuries are actually very common. And of all trauma patients, it has the worst outcomes if it's not treated properly. And a lot of the initial management, which is secondary preventative measures, can be done at a primary healthcare facility. Next slide. So in terms of mechanism and pathophysiology, so you can either have a blunt or a penetrating wound, and the injury is due to decreased cerebral perfusion. So basically, at the time of injury, you have release of inflammatory mediators, which causes oxidative stress at the site of injury, causes vasospasm and ischemia to the brain tissue or bleed, and that eventually causes cell death or tissue death. So what we're trying to prevent is the secondary injury. Sorry, that's supposed to say CPP, which is cerebral perfusion pressure. So if you have decreased cerebral perfusion pressure, which is basically a surrogate for your cerebral blood flow, you have ischemia. And if you have raised intracranial pressure, it can cause multiple negative outcomes because of the whole Monro-Kelly hypothesis, which basically is that in the cranium, it's a fixed space and is made up of three constituents, which is your brain tissue, your CSF, and blood. And if there's an increase in any of these constituents, the other constituents will decrease in size or compromise themselves to accommodate for the increase in the other component. So if you just look at cerebral perfusion pressure, just so you know what it's made up of, it's basically your MAPS minus your intracranial pressure. That's why in secondary prevention, which I'll get to now, you try to maintain your MAPS and decrease your intracranial pressure. Okay, next slide. So with any management of any trauma patient, you'll use your ATLS principles. So with head trauma, there's often an associated C-sign injury, so it's important to immobilize the spine. In terms of airway, we use our GCS scale to sort of determine how to treat the airway. So if a patient has a GCS of less than 8, the patient should be intubated using a rapid sequence induction. A lot of this goes together with the breathing component of your ATLS principles. So we want to maintain normal carbia, which is essentially between 30 and 35. The problem is either end of the spectrum, either hypercarbia or hypocarbia, can cause further cell death and can worsen long-term morbidity and mortality. In terms of ventilation, the recommended induction agent is ketamine because it has the least hemodynamic instability. And then obviously throughout the resuscitation, you want to keep them on continuous pulse oximetry because you want to also maintain O2 levels to supply adequate oxygen to the remaining brain tissue. And then once the patient is intubated, you will have to keep them on continuous capnography so that you're maintaining normal carbia. Then in terms of circulation, so there's different schools of thought in terms of the fluid of choice, but a large majority of the articles say that you must keep MAPS above 90. So we also don't recommend the use of pure crystalloid resuscitation because it actually increases your risk of thrombosis and secondary injury and infarcts. So what they recommend is rather maintain blood pressures using a combination of crystalloid solution and inotropes. And if the patient is anemic and you have blood products available, use your blood products. So it's a combination of all three factors to treat the hypotension. Then with any head injury, you have to assess for neurological fallout. So if the pupils are equal and reactive to light, if there's any focal neurological signs, and then we use our GCS score, which is our severity scale in head trauma. Then we expose the patient head to toe, because often we are distracted by the patient's low GCS or focal neurological signs that we miss other areas of trauma. So it's important to look at the chest, look up the abdomen, make sure that there's no stab chest, no stab abdomen. And then, but you can't take too long for this, because hypothermia has also been shown to worsen outcomes in head trauma patients. So you do a quick head to toe and then you cover the patient immediately. And then so not all head trauma patients will have a GCS of less than 8. Some of them will be able to speak to you. So it's important to ask questions about signs of raised intracranial pressure. So ask about headache, drowsiness, visual disturbances, back pain, continuous nausea and vomiting, convulsions, pulsatile tinnitus, and loss of consciousness. Okay, next slide. So this is basically what I was talking about. I'm sure we've all come across this. So there's an actually misnomer about the GCS scale. So a lot of us write in our notes for every patient that comes into a clinic, GCS 15 out of 15, but it wasn't designed for the ordinary patient. The GCS scale was actually specifically designed for traumatic brain injury. So it's really pertinent to patients with head injury. It's a score out of 15 and is made up of 3 components: an eye component, a verbal component, and a motor component. And at the bottom there, you can see the different severity scales. So severe TBI is anyone with a GCS of less than 8. If the patient is intubated, you take out the verbal component and the score is then out of 10. Okay, next slide. So everything up to this point could be done at a primary healthcare level. So this should be done quick and efficiently. So they say it's a golden hour, but the ideal is the platinum 10 minutes. So if we can do all of these things within 10 minutes, that's the ideal, but it's not practical. So try within at least an hour. Reasons for referral to get imaging is patients with a low GCS, any change in level of consciousness, or a history of loss of consciousness has to be referred to a tertiary healthcare center. At the center, they'll do a CT brain. The CT brain has to be non-contrast because, as Yair said, contrast is the same color as blood. So if you do a contrast CT scan, you may miss a bleed. In addition to looking for intracranial bleeds, you'll also look for features of raised intracranial pressure. So those are effacement of the ventricles, of the basal cisterns, and all other CSF spaces, any signs of brain herniation, and loss of gray-white matter differentiation. And if there is a bleed present, contact neurosurgery so they can see whether or not it is for neurosurgical intervention. Next slide. I thought it was important just to cover our osmotherapies as well, because even though we wouldn't do this in a primary healthcare setting, we probably will all work in an ED at some point in our lives, and it's important to consider these. So these we do under neurology consultation or neurosurgery consultation. So basically the principles of these therapies, they act as a diuretic. So they draw fluid from the brain and excrete it in the urine. So mannitol has been the gold standard for many years. It was the first hyperosmolar agent to decrease intracranial pressure. It's basically a protein that draws fluid with it. So how do we give it? So the recommended dose is between 1.5 to 2 grams per kg over 30 to 60 minutes. So we do it in patients who don't have a massive intracranial bleed, but are not improving GCS-wise or are getting progressively worse, and there's features of raised intracranial pressure on the CT brain. In studies, they've shown that higher doses of mannitol, so up to 1.7 grams per kg, have been more effective than lower doses. So there was a trial that studied that, and doses at 1.4 and 1.7 showed to have better long-term outcomes. It's important when you give mannitol to look for common side effects. So that includes angina, congestive cardiac failure, hypotension, hypertension, phlebitis, seizures. It worsens metabolic acidosis. It can cause electrolyte disturbances, nausea and vomiting, and urinary retention. So with all of these patients, they need a high care setting where they can be observed continuously and regular blood gases to monitor electrolytes. The other newer kid on the block is your hypertonic saline. So hypertonic saline has a similar mechanism of injury. So sodium draws water with it. And it actually has been shown to have a longer effect than mannitol does. So mannitol's duration of action is usually 150 minutes. Hypertonic saline about 550 minutes. And it actually shows to decrease intracranial pressure more than mannitol. The problem is that it has worse side effects. So it can cause a pontine myelinolysis, and it can also cause rapid shrinking of the brain, which can tear bridging vessels and in the end cause worse neurological outcome. However, it has been thought that patients with normal renal function and patients without chronic hyponatremia are unlikely to have these side effects. So you kind of have to weigh the pros and cons and see what the best outcome for your patient will be. Next slide. So long-term management is really about rehabilitation and early referral. So early OT, early physio, if the patient has speech deficit, to speak to a speech therapist as soon as possible, dietitian if necessary, and it's basically just symptomatic management of whatever fallout the patient has. And then, so in conclusion, we can't reverse the primary insult, but we can prevent further injury through all of our secondary preventative measures. Our management should be quick and efficient, and early referral is really important. And then the next slide is just our references.
Thank you very much. Let's get some thoughts on how people felt your presentation was. So here's a chance to give feedback. Remember that in primary care, you know, I know that you guys are seeing yourselves as interns and thinking about yourselves moving through other parts of your internship, but you really are getting ready in this 6 months in primary care. And so rehabilitation is a whole lot more important for you than what you might have to do in high care settings, which are not going to be where you land up necessarily, even in your ComServe and perhaps for the rest of your life. But rehabilitation becomes really the big problem and a very difficult problem and worth focusing on. Anyway, let's leave it at that. Let me ask if there are any comments from any other questions. I see somebody's got their hand up. Michelle, go ahead.
Hi again. I just picked up on something, which I quickly went and checked because we were taught a little bit differently a couple of years ago. But I was just interested in the use of ketamine and head injuries. And previously, I mean, you learned that ketamine caused raised intracranial pressure and possibly affected cerebral perfusion pressures. But I just went and did a quick search, and apparently there have been a lot of studies since to actually say that that isn't true, and that's a myth that's been hard to get rid of. And that it's quite a good drug in maintaining respiratory function, blood pressure, and doesn't necessarily cause the raised intracranial pressure that we learned about a long time ago. I just picked up on that.
Great, thanks for that share. Thanks, Michelle. Any other comments from any other family physicians or any questions from any of the groups, any of the interns? Okay, I think I shared the results. So let's stop at that. Dr. Aki Petkova. Anyone commenting
yes,
before we close?
Yes, perhaps just one comment. How many stroke centers do we actually have, say, in Gauteng that we are aware of? Perhaps the presenters can give us that information.
In private, there are quite a few stroke centers. In public, I know that Barra wouldn't fit the criteria, the ACS criteria of a stroke center, but they are striving for one, as was Joburg Gen, where the fibrinolysis was common. And I know Helen Joseph is in the process of setting up a stroke center as well. I'm not sure about out of Gauteng area, but in our circuit, all three of those hospitals can actually perform fibrinolysis.
Yeah, I think the point is it's really limited in terms of service-wise, probably at a tertiary level. Dr. Petkova?
I know that Professor Motara from Charlotte is having a team which is even connected with an ambulance, and all her team members reporting to one cell phone, which is with someone who is ready to activate the process, yes, for patients who are in the first 6 hours of stroke. And I know that she's in kind of team at Charlotte, but apart from that, I'm not sure.
Well, it'd be great if you can send that number that she's using, because it might help us in terms of access as clinicians on the ground. So I'm sure interns and others will find it very helpful if they think they can access services at Charlotte. I'm not sure if it's a research attempt as well, but nonetheless, it's a very useful resource. Maggie, would you be able to get that number and share it, and I'll put it up on the website?
I'll try to do it, Prof. Thank you.
Good. Thank you very much. Very useful. Any other comments, questions? None? Well, thank you very much. It was great. Lots of learning, and enjoy the week, and we'll see you next week. Take care, everyone.